The following podcast is part of a certified educational activity titled Novel Strategies for Managing Patients with CKD-Associated Anemia. What do health system pharmacists need to know about HIF-PH inhibitors? Access the entire activity and complete the post-test at peerview.com/HFV860. Downloadable slides and practice aids are also available.
Hello, and welcome to our session, Novel Strategies for Managing Patients with CKD-Associated Anemia. What do health system pharmacists need to know about HIF-PH inhibitors? Today's panelists include myself, Jay Wish from Indiana University, Joanna Hudson from the University of Tennessee, and Ellie Kolopouros from the University of Pennsylvania. So I'd like to turn the podium over to my colleague, Ellie Kolopouros, who's going to discuss the benefits, limitations, and mechanisms of action in current emerging strategies for monitoring and monitoring CKD-associated anemia. Ellie?
Thank you. Thank you for the invitation. Thank you for coming here today. When we discuss CKD-associated anemia, really we have to recognize the problem, which is really increasingly being recognized as a heavy burden, very high incidence. First of all, CKD treatment is suboptimal in the United States, actually in the world. 15% of US adults, some new data, have chronic kidney disease, and the definition of CKD is evolving, and I would like to share that with you later. Only 36% of patients with CKD receive an ACE or an ARB, a RAS blocker, which is really the standard of care for management of proteinuria and hypertension in chronic kidney disease. So the question is why? Why is it so low? And greater than 550,000 Americans are on dialysis in the United States, but there are, you can see, millions with CKD stages 1 to 4, non-dialysis. Why are only 500,000 patients on dialysis? Is because there's an increasing mortality, increasing death in our patients, and anemia is one of the contributors to that mortality and those bad outcomes. So I alluded to that CKD staging is really becoming more nuanced, and here it's defined by declining GFR and albuminuria. So albuminuria is a very important key determinant of staging of GFR. And when there is albumin in the urine, it indicates there's increasing damage to kidney function, but also I'd like to share with you that albumin in the urine is a surrogate marker for cardiovascular disease and endothelial dysfunction. Those are the comorbidities our patients with CKD are dying from. So we are tracking UACR very carefully early on in the course of chronic kidney disease, whether a patient is diabetic or not. And this is what we call the KDIGO. It's a practice guideline for nephrologists, the KDIGO heat map. Red is bad, green is go. And what you can see here, the stages of GFR go from G1 to G5, again defined as kidney failure, G5 less than 15 mLs per minute, people on dialysis. And you see that even if you have near normal glomerular filtration rate, which is 90 to 104 or 75 to 89, the green, if you have very high protein in the urine, then you really are risk stratified at a very high risk level and need to be treated just with that for albuminuria. So it's not just the level of GFR drop, but the presence of albuminuria that really risk stratifies our patients. So we know we've increasingly been recognized that we have increasingly recognized, that racial and ethnic disparities exist in chronic kidney disease and in the treatment of those patients with chronic kidney disease. So the highest risk populations, we call the vulnerable populations, or minorities, are the majority. Those are the higher risk, and yet they have less medical care or less access to medical care. The rates of kidney failure from diabetes by race and ethnicity in 2013, and actually more current data, show that the burden of disease really is placed on minority populations, predominantly Black and Hispanic patients, and the presence of clinical risk factors for CKD and patients screened for CKD among Black participants, only 24% of those patients are screened for chronic kidney disease. So I guess it's on us as healthcare providers to recognize that as a real problem and really work towards correcting it. You also see that the proportion of patients that did not receive care from a nephrologist prior to hemodialysis also varies by ethnicity, with the majority of patients being Hispanic and also African American. So that patients are dying of chronic kidney disease. They may not be aware that they have it, and yet, as a healthcare community, really, we are not really acting quickly enough to really remedy that situation. So CKD-associated anemia is really a significant then public health challenge. I say to you that patients die of cardiovascular disease, increasing morbidity, and the anemia prevalence increases as you lose kidney function. So up to 87% of patients on dialysis have anemia, actionable anemia, which we define as less than 10 grams. Anemia accelerates the progression of chronic kidney disease and also increases the already high costs associated with CKD care. Anemia in chronic kidney disease also reduces quality of life in our patients, increases cardiovascular comorbidities we talked about, hospitalization, and mortality. And I will just tell you that in my own experience and really in published data, universally patients with chronic kidney disease care more about how they feel than longevity. So their lifespan is shortened. It's not as short as it used to be, but the quality of life indicators and anemia with fatigue, shortness of breath, feeling lousy every day, they would rather feel better than live for 20 years with those symptoms. And Dr. Hudson will further develop that concept in her talk. So the prevalence of CKD-associated anemia in an anemic cohort, non-anemic cohort, for the minority populations, as I discussed, 70% of the anemic cohort are, under our vulnerable population, whereas 78% of the non-anemic cohort are as well. So it seems that the vulnerable populations in our specialty really are the Hispanic and African Americans or Black Americans, as well as Native Americans are in that group as well. So what you see here is that this, which is an important determinant of risk, is socioeconomic status. So we're increasingly recognizing that low income and less than high school education literacy level, really, there's a higher incidence of anemia in both those domains. And you would ask why? Why is education important? Well, every patient needs to be educated in a different way in the language they understand that anemia is something that can and should be corrected. So these social determinants of health really are increasingly playing really an important role in CKD-associated anemia. And many of these factors lead to anemia and to progressive CKD. And we're born with the genes that we have, but we can modify some of those genes by therapeutic interventions or modify the outcome or the phenotype of those genes with true medication, education, and also the environment that those patients live in really alters the way that they are treated, and their access to care is really important. So we really have to look at these social determinants of health very carefully in our vulnerable population so that we can address them. I want to point out one thing that is really became stunning to me when I reviewed some of these data, and that is the low birth weight, which is at the bottom of that slide. So the numbers of glomeruli, the filtering units that your kidney has that filter blood, are determined from the day you're born. And when you have low birth rates, you have low numbers of those glomeruli. And then low numbers of glomeruli with low birth rate lead to progressive kidney disease and some glomerular diseases like focal sclerosis, which is a disease that has a lot of proteinuria. So if you look at our vulnerable populations, many African American patients really do have low birth weights. So we're not pediatricians, we're adult nephrologists and adult practitioners here. But one of the questions that pediatricians always ask is, what was your birth weight? So you guys need to memorize that. So etiology of CKD-associated anemia is multifactorial. So why patients with chronic kidney disease getting anemia? So this is a busy slide, but the pathophysiology of this involves several processes. First of all, the kidney is an organ that is very inflamed, so it's high inflammation in the center, but also has disrupted renal oxygen sensing. And I'll further go through that in a couple more slides, and Dr. Wish will discuss that in detail. But the kidney lives the renal oxygen sensing in the kidney is disrupted. You need oxygen for life, right, for breathing, but you also need oxygen for other gene transcription, which includes some of what we're going to talk about today, which is the production of erythropoietin and how this HIF pathway that we're going to define really is affected by chronic kidney disease. And in that sense, it leads to reduced erythropoietin production. Without erythropoietin, you can't stimulate the bone marrow to make cells. Again, CKD is a model of inflammation with high inflammatory markers. And the inflammation not only leads to reduction of EPO production, but also decreased red cell lifespan. But importantly in this slide is really the appearance of and the notoriety of this molecule hepcidin. So hepcidin was discovered and really increased our knowledge base of iron metabolism, and because it is really the master regulator of iron metabolism in our body. It's the gatekeeper to iron mobilization from storage sites such as the liver, the hepatocytes, and also absorption from the GI tract. So what happens in CKD simply is that as you lose kidney function, less of this hepcidin is cleared, more accumulates in blood, very high levels, and blocks iron from being released from the storage places. And so all this really conspires to lower plasma iron, decrease erythropoiesis. There's also blood loss, particularly in our dialysis patients on dialysis, when they lose blood through various reasons while they're being dialyzed, interrupted circuits, or blood within a dialyzer. And all of those conspire to lead to anemia. So there's a difference. Not only is erythropoiesis important, right, the presence of the hormone erythropoietin to stimulate bone marrow production of mature red cells, but iron is a co-player in this domain. And what you see here is that absolute iron deficiency, so our patients are iron deficient on dialysis. Absolute iron deficiency is defined as no stainable iron in storage tissues. Now, if we were purists, we would do bone marrow biopsies on all patients to see whether there's iron staining in their bone marrow, but it's a very invasive test, so we don't really do that. We have other surrogate markers. And so in absolute iron deficiency on the lower panel, the serum ferritin and the indices of iron stores, the serum iron and the transferrin saturation, are low, and the hemoglobin is low. But in functional iron deficiency, which is what most of our dialysis patients and our advanced kidney failure patients have is functional iron deficiency, where you see that the serum ferritin is high, but the iron and the transferrin saturation and availability of iron are low, and the hemoglobin is also low. And functional iron deficiency really is a direct result of increased hepcidin in patients with chronic kidney disease, because we can't mobilize the iron that's in the storage that's reflected by the serum ferritin. Now, I must say that serum ferritin is not only a storage term for iron storage, but it actually is it's actually also an inflammatory marker. And if you were to co-measure ferritin with CRP, they would co-migrate. So ferritin is both a storage sort of indicator, but also an inflammatory marker, and both are high in patients with kidney disease. So I alluded to the fact that there's an oxygen sensing dysregulation, sort of a maladaptive response in the kidney. And the chronic kidney disease impairs the kidney's ability to elicit an erythropoietic response to hypoxia. So when you're hypoxic, right, you want to get more oxygen. Because that's the definition of hypoxia. Well, the kidney, in normal situations, the kidney tissue oxygen or plasma oxygen level of supply equals demand. One doesn't exceed the other. In kidney disease, what you see here is that although you have a kidney that has, a diseased parenchyma, that the kidneys, filter our blood and hold on to electrolytes, filter blood and create urine, but hold on to electrolytes. And one of the most important electrolytes is sodium. So in order for our kidneys to hold on to sodium, there's a lot of energy being dispensed in the kidney, in the proximal tubule, as well as the loop of Henle and other parts of the kidney. When you have really energy is consumed, and when you have kidneys that are not working very well with low GFR, then their filtration really decreases. So they don't filter as much blood, right? And so therefore, the sodium reabsorption that I talked about, the electrolytes that would be really increased normally, decrease. So there's a decrease in sodium reabsorption, and therefore there's no energy being consumed. And it appears like if there were energy consumed, the oxygen levels would fall. But because energy is not being conserved for the transport of this molecule through the sodium-potassium pump and channels, et cetera, what you see is that the oxygen level in the peritubular cells remains high. And so the kidney, although it's damaged, the oxygen level is high, and those cells, that's where erythropoietin is generated. That's one of the questions, right? It's generated by the renal epithelial cells called pericytes that surround the proximal tubule and other tubules that sense that dysregulation of oxygen. And really, that's the key based on which the PHIs, or the HIF protein, the HIF pathway has really been developed, and Dr. Wish will talk to you more about that. So there is disrupted oxygen sensing in the kidneys because oxygen level is high, and the kidneys they're fooling the system and saying, well, we don't really need to make more erythropoietin because the level is high. And it's pseudonormoxic. That's a new term for me too. So it's a pseudonormoxic state. So it's a sort of maladaptation. And there are also a reduced number of these rep cells that I talked to you about, the renal epithelial pericytes in the kidney, available to sort of elicit this hypoxic response. So we'll talk a little bit more about hepcidin because it's a very important molecule, and it's redefined how we think about iron metabolism and iron mobilization. So hepcidin regulates iron metabolism, and as I said to you, it's often, elevated in patients with kidney disease because there's reduced clearance of hepcidin, there's inflammation with inflammatory markers like IL-6 being produced, there's increased iron stores in the liver, and so since hepcidin blocks this release of iron from the storage cells and absorption from the duodenum, what happens is that you continue to keep iron in the stores, but not available for it and it won't be mobilized, so you have this functional iron deficiency state that we talked about. And it's really, really important to recognize that hepcidin goes up, starts rising early on in kidney disease, but reaches levels at the point where patients are on dialysis with very low GFR, so very high hepcidin levels. And one of the questions you might ask is this hepcidin measurable, and can we treat it? Can we inhibit it? And I can say no, not in clinical practice. We haven't really come that far, but it can be manipulated in animal studies. And with inhibitory compounds. So evaluation of anemia and basic management of chronic kidney disease. Really, you see these stage 3, 4, 5, and stage 5D on dialysis. I think it's reasonable to monitor levels of anemia and iron studies in patients with CKD stage 4, 5, and 5 on dialysis. I show here an algorithm just to focus on what we think about when we take care of patients. When you have these chronic kidney disease, check the hemoglobin. You see the definition. And then, you have to measure iron stores and treat with iron if patients are iron deficient. And then if anemia is not corrected with iron, then you would add an erythropoietic agent like ESA or erythropoietin to raise the hemoglobin to at least above 10 grams per deciliter. So the benefits and limitations of current treatments for anemia and chronic kidney disease are listed on this slide. First of all, iron therapy is key, oral or IV iron. You can give oral iron, but you require a lot of oral iron in order to replete your iron stores. So intravenous iron is recommended usually for severe anemia, severe iron deficiency anemia, particularly in dialysis patients after they failed a trial of oral iron. And the limitations are that oral iron may be ineffective or poorly tolerated. There could be allergic reactions that cause hypotension. ESA therapy is actually a barrier sometimes because sub-Q injection and intravenous administration are the only forms, whether these other agents that we're going to talk to you about are oral. They're not always effective. You can treat patients, but there's not always effective erythropoiesis, and they're hypo-responders. So this is an unmet clinical need in our patients. And then finally, transfusions, which it used to be the gold standard before even erythropoietin was made available in recombinant form. And when you transfuse patients with chronic kidney disease, they're allosensitized to foreign antigens, and kidney transplantation is limited for those patients. So where are the gaps in the treatment of CKD-associated anemia? Obviously, the most anemic patients are in CKD stage 4 and 5, and also the patients on dialysis. So those are the patients, as I said, with actionable anemia, hemoglobin less than 10, and so this is something those are the patients that we screen and follow carefully, usually every 3 to 6 months and annually if you have stage 3. Transfusions are the predominant treatment in non-dialysis CKD, and these, as I said, potentially interfere with future transplant eligibility. Insurance doesn't change that. So how can we now harness this hypoxia to treat anemia and chronic kidney disease? And that's really why you're here today, to hear about these new innovative agents. The body naturally makes more red cells in oxygen-deprived atmosphere in high altitudes. We know that patients in high altitudes have a lower prevalence of anemia. And also, what's really important and exciting is that 2019, Sir Peter Ratcliffe, a nephrologist in the United Kingdom, won the Nobel Prize for understanding how these hypoxia-inducible factors, the HIFs, regulate oxygen levels at high altitude, and how can we leverage that to treat our patients with dialysis, so with kidney disease. So with that, I'd like to turn this over to Dr. Wish, Jay Wish, who's going to talk to you really about the future of these agents. Thank you.
Thank you, Ellie, for providing a beautiful introduction in terms of some of the unmet needs for current anemia treatment. And we try very, very hard, but not all patients do respond to our therapies despite our best efforts. And as Ellie mentioned, our understanding about the pathophysiology of anemia and chronic kidney disease has advanced tremendously over the last 20 or so years. We used to think naively that anemia and chronic kidney disease was merely an EPO deficient state, that diseased kidneys just made less EPO, and if we give them back EPO, just like you give a type 1 diabetic insulin, that would solve the problem. And we've learned that obviously there are many other nuances that go into the pathophysiology, hepcidin and now HIF, that we can ultimately leverage in terms of making patients less anemic and perhaps improving their quality of life. So just to kind of go into more detail in terms of the physiologic role of HIF and prolyl hydroxylase, which is the enzyme that degrades the alpha subunit of HIF in the presence of oxygen. And you can see what happens in this slide. In the presence of oxygen, these HIF prolyl hydroxylase enzymes are activated, and they basically do what the name suggests. They hydroxylate the proline residues on this protein, HIF-alpha, and this changes its three-dimensional configuration so that it becomes recognized and targeted for destruction by several enzyme systems, including ubiquitin and von Hippel-Lindau factor. In the presence of low oxygen, such as might be encountered in high altitude, these HIF prolyl hydroxylase enzymes do not become activated because they require the oxygen for activation, and the HIF-alpha subunit survives and migrates to the nucleus of the cell, where it heterodimerizes with the HIF-beta subunit, which is always present, and this leads to transcription of a variety of genes. And again, since these proteins, hypoxia-inducible factors, are designed, they evolved to basically adapt the cell and the tissue to a hypoxic state, there are a variety of consequences that help with that adaptation, most notably increased erythropoiesis. Because if less oxygen is coming to the tissue, you can basically do a couple of things to improve oxygen delivery. One is to increase the carriers of that oxygen, namely the red cells, and the other would be to increase the number of vessels by which those red cells travel, and that would be angiogenesis. But if we focus on the red cells, there